Welcome back, everyone. We're going to continue the toxidrome series with this lecture looking at asphyxiant and inhaled toxidromes. Carbon monoxide is a common EMS call, and it's something we need to be aware of and understand how the management and presentation of these patients work. Fatal exposure is associated with using things like gas-powered heaters in confined spaces. This is especially common in the wintertime during the first cold front or the first time that folks may be using combustion devices to heat their house. We can also see it in house fires or running vehicles in a closed garage. It's a colorless, odorless, tasteless gas, and the problem with carbon monoxide is it displaces oxygen at the hemoglobin level and prevents oxygen from getting to the tissues. The suffocation doesn't occur by asphyxiation or lack of air movement, rather it occurs at the cellular level. Signs and symptoms are variable and can be vague. Can include subtle signs such as headaches, fatigue, nausea, tachypnea, tachycardia, and confusion. But as the patient continues to become exposed, they can lead to unconsciousness and ultimately lead to asphyxia or suffocation. Management for these patients includes administrations of high concentrations of O2. This isn't going to debind the carbon monoxide, but the treatment theory here is that if we create an excess environment of oxygen, that as the carbon monoxide debinds from the hemoglobin, then there's a ton of oxygen molecules readily available for it to be picked up. The hallmark care is oxygenation and removal from the environment. We may need to establish and maintain an airway, and we may consider the use of additional measures such as CPAP or intubation and artificial ventilation via a ventilator to ensure that we're getting 100% O2 to these patients. Ultimate long-term care is going to revolve around the patient, most likely going into a hyperbaric chamber. So this is another treatment decision or transport decision that you need to be aware of. If hyperbaric chambers are available in your area, this is where that patient should be going to. Chlorine gas are compounds that are commonly used in the home and in occupational settings. Household ingestion can occur due to unlabeled containers or accidental ingestion or acute exposures arising from industrial accidents or valve pump malfunctions. Pathophysiology for this includes, for a minor exposure, you may have burning sensations to the eyes, nose, and throat, or a slight cough, while severe exposure can include things like cyanosis, seizures, and shock. For assessment and management of these patients, you want to make sure that you remove patients from the area and triage accordingly if there's a large number of patients. Deliver high concentrations of humidified O2, and you may need to irrigate any burning or itching eyes, and as well as irrigate the skin. Patients with respiratory distress are going to be your priority and your most acute management criteria here. Cyanide is a gaseous form of hydrogen cyanide. It's often colorless with a bitter almond scent. It's rapid acting and it's a deadly poison. It combines with cytochrome oxidase, which blocks the utilization of oxygen at the cellular level. Death typically occurs within seconds if inhaled, and within minutes to an hour if it's been ingested. The patient may present with altered mental status, but may include other signs such as headache, nausea, vomiting, anxiety, vertigo, weakness, or dyspnea. Management for cyanide poisoning should be treated as quickly as possible. Start with 100% O2 via non-rebreather mask or bag valve mask ventilation. And then the goal becomes to displace the cyanide from the cytochrome oxidase by introducing another chemical to bind to it. And this is where your cyano kit comes in. These are generally not kept on every ambulance, but most EMS services have access to them. They might be kept on a supervisor's vehicle or back at a main headquarters station. So if cyanide is suspected during dispatch, then the additional resources should be asked for then so it can be on the way. They have amyl nitrate and another medication that I can't pronounce and won't make a fool of trying to pronounce. If available, you can break the amyl nitrate into a gauze and hold over the patient's nose. Monitor patients closely during transport. This is the other medication, hydroxycobalamin, I believe is how that's pronounced. Sorry. Understand that the receiving facility needs to know if you've given this as well, because it can skew findings in lab samples as well. Methylene blue is also an antidote that's used to treat one of the complications of cyanide, which is methylglobinemia. It has an alteration of the hemoglobin, and it's induced by amyl nitrate and sodium nitrate, and it can be administered under guidance of an expert. We don't generally give this in the pre-hospital setting, but it may be something you encounter in the facility. Hydrofluoric acid and hydrogen fluoride. So hydrofluoric acid is hydrogen fluoride that's been placed into an aqueous solution. It's primarily used in industrial settings. Toxicity can come from a very, very small amount, and the problem or the patho of this particular exposure is that it leaches calcium and magnesium from the body. This creates a profound state of hypocalcemia and hypomagnesemia and leads to a massive release of sequestered potassium. So exposure to hydrofluoric acid can have significant implications systemically through the body. And for paramedic providers, it's going to be extremely important that we're paying attention to cardiac function here, because the reduced calcium and magnesium, along with the increased potassium, is going to create very dangerous and deleterious cardiac dysrhythmias. Also need to be on the lookout for tremors, seizures, CNS depression, and acidemia. Treatment is going to be based on exposure level. For inhalation causes, throat discomfort, bronchospasm, stridor, airway injury are all common. For ingestion, we may see gastritis, abdominal pain, vomiting, and systemic toxicity. Airway breathing and circulation are going to be your priority, top priority, all certification levels. For ingestion, we're going to provide stomach evacuation. This will usually come through NG or OG tube, and then administering calcium and or magnesium containing substances. So you would be expected to administer at the paramedic level magnesium and calcium both to try and prevent or mitigate the hypocalcemia and hypomagnesemia, as well as combat the hyperkalemia that's associated. Hydrogen sulfide, pathophysiology for this is a highly toxic colorless gas that has a rotten egg odor. Poisoning usually occurs through inhalation. It affects all organs but has the most impact on the lungs and central nervous system. Low-level exposures can create things like headaches and bronchitis, while very high exposures can create seizures, coma, cardiopulmonary arrest, and shock. For management, there's no proven antidote for hydrogen sulfide. Remove the patient from the contaminated area and then support airway breathing and circulatory status. For oxides of nitrogen, nitrogen dioxide is a form of byproduct of fuel combustion. Exposure can result in irritation of the throat and upper respiratory tract. You may also see a buildup of pulmonary edema or fluid in the lungs. An assessment and management for this is going to be largely supportive and ensuring that we remove the patient from their environment. Advanced level providers may need to engage in fluid resuscitation through IV access and then be prepared for advanced airway measures for these patients.